Good evening, everyone, and welcome to the Better Healthcare Through Communication webinar. My name is Cristina Schaefer, and I'm a volunteer with the Arthritis Foundation. I'm involved in the local level in Houston, Texas, serving as the Houston board chair and serve in several roles nationally, including as co-chair for the National Walk to Cure Arthritis. I'm also someone who's been diagnosed with rheumatoid arthritis for over 18 years and understand the importance of communication with your healthcare providers. Arthritis can be a complex condition, and how you communicate with your healthcare providers can influence the type of treatment and the care you receive. Studies show that strong doctor-patient relationships are strongly linked to improved health outcomes. In this webinar, we'll discuss how to effectively communicate and build trust with your arthritis healthcare team. You'll also gain strategies for building successful doctor's appointments, including how to express concerns, provide vital information about your conditions, and ask questions about trickier subjects. Before we get started, we have a few housekeeping notes about tonight's webinar. We've muted all attendees for this event, but you can direct any questions or thoughts that you have throughout the presentation to the Q&A box at the bottom of your screen. Tonight's discussion will be broken down into two parts. First, we'll have a roundtable discussion informed by pre-submitted questions. Then we'll move on to a brief live Q&A. After tonight's session, you'll receive an email asking about your experience during this webinar. These surveys help the foundation better plan for future events, so please take some time to fill that survey out. A recording of tonight's event will also be included in the second post-event survey email, as well as be available on the Arthritis Foundation's YouTube channel and the Webinars Hub a week after this event takes place. You can also register for upcoming webinars in 2024, which are hosted monthly in the Webinars Hub. Let's start by introducing our guest experts for this evening. Listed here, you'll see Dr. O'Connor, who was unfortunately unable to join us this evening. She had a last-minute thing that came up, but we have two subject matter experts with us tonight. First, we have Olatunde, or Tunde for short, Oshikoya. He is a board-certified physician assistant with a clinical background in addiction medicine and emergency medicine. He obtained his Master's of Physician Assistant Studies degree from the University of Florida in 2018 and is currently enrolled in A.T. Still University's Doctor of Medical Science program. In 2020, he opened Rapid Recovery Mobile Clinic, a remote clinic that provides convenient point-of-care testing and treatment to the Atlanta metropolitan area and surrounding counties. The clinic was created to address systemic problems and barriers to care, such as lack of access to reliable transportation, healthcare, and health insurance. Due to his long-lasting commitment to civic engagement, his alma mater created an academic STEM scholarship fund for 2 African American students. We also have with us Dr. Colin Edgerton. He served as the Rheumatology Service Chief at Eisenhower Army Medical Center from 2006 to 2013, where he held faculty positions in the Medical College of Georgia and the Uniformed Services University. He's a pioneer in musculoskeletal ultrasound and established the ultrasound training program at the Medical College of Georgia. He serves on the American College of Rheumatology Ultrasound Task Force and has published national guidelines on the use of ultrasounds by rheumatologists. He holds national leadership positions in the American College of Rheumatology and the American Medical Association. Dr. Edgerton joined Low Country Rheumatology in 2013 after serving 12 years as a U.S. Army physician, where he achieved the rank of Lieutenant Colonel and earned a Bronze Star for Valor while deployed to Iraq in 2008. Welcome to the webinar to our subject matter experts, and we thank you so much for joining us tonight. Hey, I think we're just waiting to get Dr. Edgerton on camera, but I think we'll go ahead and kick off tonight's discussion with a review of the importance of having a well-rounded team for arthritis care and what that looks like. There we are, Dr. Edgerton and Tunde. On this one, I think we'll start with Dr. Edgerton. Would you like to get us started on this? What does a well-rounded healthcare team look like for arthritis?
Oh, it's a great question. Thanks, Christina. I'm so excited to be here tonight to talk about this. Well, I think it helps to understand the basics behind arthritis, that there's two general types. There can be arthritis that is due to mechanical factors, injuries, and age-related wear and tear. And then there can be arthritis related to inflammatory factors, autoimmune diseases, and other diseases that cause the immune system to attack the joints. And I think having specialists that are robustly trained to address both types of arthritis is important. So certainly orthopedic surgeons and rheumatologists cover both of those kind of realms of arthritis, and there's quite a bit of overlap. But it's really important to understand that there are other specialists who have a really important role. The quarterback always being the primary care physician. There's a lot of arthritis complaints that are primarily dealt with at the primary care level. And then other supporting specialists to include neurologists and physical medicine physicians, physiatrists, and then beyond the physicians and the healthcare providers who work with them, there can also be physical therapists and pharmacists. So the team can kind of grow, and we'll talk a little bit about helping patients navigate all those different personalities tonight.
Very good. Tunde, do you have anything to add there? We had a question, what about orthopedists? Do they have a role in arthritis other than surgery?
Yeah, great question. And to echo Dr. Edgerton's points, definitely want to extend my gratitude for the invitation this evening. Looking forward to an insightful conversation. So as it relates to the original question, I think Dr. Edgerton covered it pretty well. It's been in my experience with my emergency medicine background. Oftentimes patients, if they are unable to get to those identified healthcare providers, oftentimes they actually do go to their local urgent care or emergency medicine room for those acute exacerbation pain management. So it's important to also recognize and be able to identify, what's something that could potentially be managed better by your primary care provider or your orthopedic specialist versus that might need to be handled more acutely in the urgent care setting, whether it be with acute treatments or acute imaging.
Very good. Now, do these experts vary depending on if you have an inflammatory type of arthritis versus a degenerative type? For example, does someone who with osteoarthritis need to see a rheumatologist or someone with gout? Dr. Edgerton?
Yeah, they really do. Although fortunately, all of the specialists who treat arthritis are pretty good at directing you to the right place if you happen to land in the wrong place. So it's not uncommon for someone who really needs to see an orthopedist to wind up seeing me first, and we can help manage and redirect them, and vice versa if they wind up in orthopedics. But there are really differences in the specialist's sort of focus. So when it comes to diseases where the immune system is attacking the joints, like the lupus-related diseases called systemic autoimmune diseases, or inflammatory arthritis like rheumatoid arthritis or psoriatic arthritis, or diseases like gout that you mentioned, crystalline disease, that's really where the focus of the rheumatologist is, because it's medical management of those diseases. Whereas for disorders that certainly might require surgery, orthopedics is the right place to be, but also non-surgical management of different musculoskeletal injuries or chronic musculoskeletal problems like degenerative arthritis. They're well managed by orthopedists as well. There's quite a few orthopedic docs who do sports medicine or non-surgical management too. And then, like Tunde mentioned, a lot of this is done at the primary care level. So that's always a good place to start. The patient doesn't necessarily need to know where to go, but touching base with your primary care physician. And then, certainly for acute matters, seeking urgent care. And I'd really love to hear Tunde's perspective on when that's appropriate, because I do think that there can be some challenges with chronic musculoskeletal problems if you do present to the urgent care setting, and hopefully they can get you headed in the right direction, but it's probably not the best place to get ongoing care for those issues.
Yeah, Tunde, do you want to weigh in there?
Yeah, definitely. Thank you. And I would agree with Dr. Edgerton. More so the acute management, right? So my clinical background, especially being from the University of Florida, locally, Alachua County, a lot of that area was kind of rural. So access was often the challenge, right? Like, especially now living in I don't want to say a post-COVID world, but post-pandemic type of environment where clinics might be overrun or access continues to be somewhat of a challenge for many. They go to their urgent care because that's just the first point of contact, right? So while I don't necessarily believe that it's best for the chronic management, and I will never try to frame it as such, I would always try to refer out and contact their primary provider or or a specialist that's on board. It's good for those acute moments where, hey, I might have had an acute gout attack, after their diet might have not been the greatest over the weekend. It was football Sunday, and they're coming in Monday morning, extreme pain in their big toe joint, and they might need a steroid shot or might need like a touch of colchicine to kind of reduce some of that inflammation. So little things like that, I would say is kind of more ideal, but certainly for the more chronic management, chronic oversight, day-to-day managing, I would definitely recommend going to either your specialist or just your primary care provider who can then refer you.
Okay. So I'd love to hear from both of you on this one. What is the best way to assist communication among these multiple specialists for better care and make sure nothing falls through the cracks? And let's have you go first on this one, Tunde.
Yeah, so I think our healthcare system, while there is still a lot of progress to be made, has certainly advanced a lot with the charting system. We have so many different modalities now, whether it be MyChart, Epic, all of these online record keeping systems in place. So it's very important just to stay up to date with that. There's both asynchronous and synchronous management of healthcare now. So meaning, you can be seen via telehealth kind of in this capacity, or you can also be seen in ways that are kind of more so just like text based or, hey, just wanted to pop my head in. These are my quick, brief symptoms. Do you have any thoughts as to what might be going on, or do I need to be seen in person? Things of that nature. So in terms of just that communication, I think the communication is there. It's just a matter of being able to appropriately access those electronic health record systems, as well as just keeping your own personal records. Like at home, I usually encourage patients to journal, when they can, to kind of observe any patterns that they might have, and feel free to just bring that in at your next appointment.
Dr. Edgerton?
Yeah, I would absolutely second what Tunde was saying. One of the challenges with the electronic health records is, when your provider sits in front of that computer, it would seem like everything should be linked together and they can see what another specialist is doing that you've seen, or someone who cared for you in the hospital. But unfortunately, a lot of the systems don't talk with each other. And so one way I think a patient can bridge that gap is trying to get copies of things, particularly if you're going to see a specialist for the first time, and you've seen someone else for something related to the condition. Having a copy with you of the most recent note from that other provider can be really helpful to share information and lab studies and things that have already been done. And then just making sure that you really keep a good relationship with your primary care physician, because they really are the quarterback. And it's ideal if they know you well and they know who you've seen, and they can reach out if they haven't gotten a note from a specialist you've seen recently and really put it all together for you. And that's really a challenge. And we can talk a little bit tonight as time goes on, how there's been a lot of strain, I think, as Tunde was referencing, on the primary care base due to the pandemic. And care in a lot of areas of the country has been a little bit more fragmented than it used to be. So it's a challenge for patients to kind of try to hold everyone who's seeing them together and make sure everyone knows what the other person's doing.
Absolutely. Well, Tunde, for many, the primary care physician or an assistant is the first person someone sees to treat arthritis. How can someone best use their primary care physician to help with other elements of arthritis care?
Yeah, great question. And so, again, I think, I try to encourage my patients to be an advocate for their own healthcare. Not to say that the provider in front of them is not going to be that, but it's always best to have two checkpoints, right? You hope that when you go to see your provider, that they're going to be knowledgeable and they're going to know everything, and they're going to be able to answer any and everything under the sun. But at the end of the day, while we might be the medical experts, I always describe my patients as the experts of themselves. Nobody knows themselves better than themselves. So in terms of helping your provider be better, it's again going back to the journaling and to Dr. Edgerton's point, bringing copies, doing everything that you can do on your end, so that when you are in that appointment, whether it be for 15, 20 minutes that you're sitting in the room with the provider, you're able to ask the important questions. You're able to engage in a way that is holistic, and you're not overlooking anything. That everything that is right in front of you is important. So being able to just utilize your primary in that way would enable them every opportunity to then refer out if necessary, or manage in-house when able.
Absolutely. Dr. Edgerton, do you have anything you wanted to add there?
No, I think you really hit it. Absolutely. That's the key, is making sure that you kind of set the stage, gather what you need, so that you just maximize that time you're spending with your provider, because how short that can be.
Mm-hmm. It's interesting because the question was framed that the PCP is usually the first person that you see when you're on your way to an arthritis diagnosis. But once you have that diagnosis, and many years down the road, if it's you have an inflammatory type of arthritis, your rheumatologist, you see them more than your PCP. So on the inverse, it's equally as important to communicate things back to that PCP, that even if you might not be seeing them as regularly as a rheumatologist.
Absolutely.
Yeah. So we're going to pivot to the meat of tonight's conversation: communication challenges. The first challenge for doctor-patient relationships and communication is time. In fact, studies say the average doctor's appointment is just 18 minutes. So with that in mind, what do you wish patients would do before or after an appointment to improve care? Dr. Edgerton, can you give some tips for those with inflammatory types of arthritis and gout?
Sure. Yeah, I'd be happy to. I think one of the key things, particularly when you're seeing a physician for the first time, and a lot of times now actually with follow-ups, is if there's some requested paperwork, to try to do that ahead of time. It can be surprising sometimes when an intake form or a medical history form is available electronically and usually sent to you by your care team ahead of time. How those things aren't filled out, and they're not done. And I know it can be really frustrating as a patient, because a lot of those forms, you're kind of doing it every time you go see that provider. But due to the kind of intricacies of how the offices work, it's how it has to be. So that you want to, if there's some sort of sheet of paper that says, hey, this is your changes in your medical history or something like that, try to get it done. And so the provider can look at it as they grab it from the door before they walk in and see you, or it's ready to go. Because they generally are looking at that form multiple times a day, and they can really quickly scan it, and it can fill in a lot of important information that they can jump right into with you. Mm-hmm. So being prepared in that fashion. And sort of as a corollary to that, again, if you've seen someone else for a related condition, or there's something you think is important, if you can bring some of that documentation, particularly imaging studies, if you have a report of what the radiologist has interpreted that study to mean, that can be super helpful. Bringing a disc with images is great, but in the rheumatology world, a lot of the more advanced imaging modalities are not things that a rheumatologist will actually read, such as an MRI. What they really need is the radiology report. And if they don't have that at the time that they see you, they really can't make any decisions related to that. And once you leave the office and they have to go track that down, it's the quality of integrating that information with your visit starts to degrade really rapidly, because they've moved on to other things and they may not really remember why you were talking about that scan with them and what was behind it. So it's just so critical to try to make sure all of that information is kind of at hand and ready to go to the degree that you can put your hands on it at the time of that visit.
Now I know we have some OA patients. I see them chiming in here in the Q&A. How are there any different suggestions for OA patients? I know Tunde, you mentioned that you suggest keeping logs or journals. Any additional thoughts on how patients could prepare before an appointment?
Yeah, I think Dr. Edgerton hit the nail on the head with everything that he was saying in terms of if there's any imaging. I know, especially in the urgent care and emergency medicine world, primary as well, but if there's any imaging that needs to be interpreted, or if there's any imaging that needs to be relayed to us, it's ideal to always bring that with you. Just because, we're able to engage in that conversation in front of you, we're able to provide the reassurance as well right there and then in terms of what the interpretation means. Because in medicine, it's not one thing. It's one thing to get images, but it's another thing you have to then do something with those results, right? So oftentimes it requires the conversation to say, hey, this is what this means now. It's not the worst case scenario. We can do conservative management. We can, this is good news. This is bad news. It requires those kind of intimate discussions. And oftentimes those conversations are best had in person. So anything like that, whether it be blood labs, imaging, that's required to obviously bring that to the visit and, just prioritize that during the appointment.
Now, I mentioned a moment ago that sometimes patients end up seeing the specialists more often than the primary care physician. So, Tunde, how much should someone share with their primary care physician about their arthritis care plan?
Yeah, great question. So, I think oftentimes because patients know the visit is limited, they might have a tendency to list out 20 different things, whether they're related or not. So I think the best thing that you can do is if you have that journal on hand to say, hey, I noticed that on Monday, I had a flare up. This is some of the things that might have contributed to it. On Tuesday, the same thing happened. That way, again, when you come to the visit, it allows us the opportunity to just prioritize the immediate in terms of what's needed to be addressed. Because, as everyone, I'm sure is familiar with, you can address 100 different things in that one visit. But it's really integral to identify the most important and say, okay, this is what we have to work with. These are the best treatment options. This is what's affordable, and trying to tackle your healthcare needs from that perspective versus the macro lens when you're in that immediate visit.
Okay. A question here about tracking healthcare symptoms. What is the best method? I'd love to hear from both of you if you have any input on this one. The best method to track healthcare symptoms, and what specific health symptoms should we be tracking? Want to go first on this one, Dr. Edgerton? Yeah.
Sure. Thanks, Cristina. This is so important. There's been such a needed focus now on what we call patient-reported outcome measures. And as you know, when you see particularly a rheumatologist for a chronic musculoskeletal problem, let's use rheumatoid arthritis as an example, you might see them 3 or 4 times a year for, as you said, maybe an average of 18 minutes, but you're living a lot of life in between that. And what you look like in those 18 minutes, 3 to 4 times a year, may not be representative of what you're really living. So it's important to be able to try to communicate all that time in between. A lot of practices will try to gather that information by giving kind of a validated tool to the patient, such as a health assessment questionnaire, which we oftentimes says, over the last 3 months, tell us what these different parameters have looked like for you. But a patient can really do a lot of that on their own too. if you, for example, each condition is a little different, but for rheumatoid arthritis, we want to know how frequently it flares up, how frequently you have swollen joints, tender joints, stiff joints, how that impacts your function. And try to think about that maybe every week and jot it down in some sort of a log so that when that question comes up, you have a better ability to answer it. Because it really can be difficult anecdotally sometimes when you're sitting in the exam room to try to figure out, well, how many times did I flare over the last 3 months? So kind of doing that proactively in whatever fashion works for you, but try to take a crack at it weekly can be really helpful.
Do you have anything to add there?
Again, yeah, I mean, I would agree. I really try to in the visit ask patients questions that are going to allow them the opportunity to get deeper. So if somebody says, hey, for instance, they might say my ankle joint was bugging me. I'll ask them specific questions like, okay, what do you mean by bugging? Or, what were you doing? Or what time of day was this happening? Little things like that, it really does matter because the more information that you're able to provide us, the more that we have to work off of, and the easier the treatment plan can come together. But if the symptoms that you're reporting are vague or inconsistent or not as specific as possible, it really can open up 20 different pathways versus maybe one or three.
Right. I would imagine, again, like you're saying, the more thorough you can be in that note taking as a patient, the better it is for everybody. Like, oh, my knee was hurting. Well, maybe that's because I went for a long walk yesterday. Maybe those are things that I need to be jotting down at the same time, or even diet as well. What did I, like you were saying earlier, oh, it was football Sunday and I vegged out all day, right? So maybe that was why I'm in a little bit of pain today. So yeah, I would think the more detailed you can be, the better. I think somebody was asking for suggestions on maybe digital places to track these things. I just track these things in my calendar. For me, everything goes in my calendar or it doesn't exist. So I just track any bad days on my calendar and I flag them with a little, they're red. You can color code them, so I know when there are bad days. But yeah, that's for me, that's what works. So let's talk about good days. Maybe what if somebody isn't having symptoms? They're getting close to the day of their appointment. Maybe it's tomorrow, and they're feeling good. Should they reschedule that appointment for a later date down the road?
I would say no, not in the rheumatology world, because typically our appointments are scheduled at certain intervals to make sure we have important kind of check-ins. It's not as important that you're having the symptoms that are representative of the problem that we're treating, even if you're a new patient. I mean, I love joking with patients when they come in. More often than not, the problem that they were referred to see is kind of minimal or non-existent. When they see me, I say, hey, it's just like when you bring your car into the mechanic and it doesn't make that noise. So we're completely used to that, and it doesn't cause the provider to kind of minimize your care at all, because we know that these kind of are intermittent, on and off flaring types of illnesses oftentimes. So keep your appointment and just be ready to talk about what it is that bothers you, even if it's not there at the time of the appointment.
Right. So Tunde, in reference to, maximizing your doctor's appointments, is there anything patients should avoid doing? Oh, I think you're on mute.
Yep, definitely on mute. Good catch. But but yeah, things that they should avoid doing. So I think it's easy, especially again going back to like all of the access we have. I think it's easy to go to Dr. Google and type in, hey, what do these symptoms mean, and get 50 different answers. I think I would really caution patients when they're doing that. I know that they're just looking for the reassurance. But that's often best provided by their healthcare provider, who has the medical education and the context to really interpret that information that you're seeing. So I would caution them about doing that. And then just with the appointments, especially in the post-pandemic world that we live in, being sure to adhere to those appointments. I know life happens, and of course, you may miss an appointment or two, but it's really important to keep a consistent schedule, as Dr. Edgerton said, maintaining those intervals and getting those regular check-ins, and making sure that you're staying ahead of it, because if you miss an appointment and now you have to get rescheduled maybe 2 or 3 months down the road, now that pain has the opportunity to potentially be exacerbated, and you could have missed a critical check-in.
Okay. Dr. Edgerton, do you think that people should maybe prioritize the questions they ask by importance?
Yeah, I think it's really helpful. And I think probably limiting that, if you can, to 3 things, as opposed, we encourage everyone to write down their questions, but in reality, yeah, you want to kind of focus on just a few that are important. And I'll add, as far as kind of things to avoid doing, you don't have to impress your provider. If you're not doing something that they told you to do or recommended that you do, and there's a reason for it, let them know. If you're not taking your methotrexate because it makes you feel nauseous, let them know there's other options. You don't have to worry about them getting mad at you. I'm there to serve my patient, and I just need the information to do it. If you drink 4 alcoholic drinks a day and you can't cut back lower than that, let them know. That's an important part of your health. No one's going to judge you, but without that information, you're not going to get a plan that works for you. So don't worry about the things like that. The more honest you can be with the information, the better your care is going to be. No one's going to throw you out.
Okay. So ask the important questions, ask them first, and be honest, right?
Yeah.
I was gonna say, yeah, that really resonated with me as well. We start treatments, but not all of them work for everyone, right? So just because we started you on a treatment, we don't expect you to come back to us and say, hey, it's working now, even if it's not working. We really want that feedback. Because if it's not working, then of course that will lead us down a different pathway, and hopefully one step closer to the correct answer, versus trying to act as though the treatment's helping, and everything is shiny and it's all good. So the more honest you can be with your provider, certainly the more tailored and close to perfection your treatment plan can be.
All right. So don't pretend to please your doctor. Got it. So decoding doctor speak can be difficult. In fact, one study shows that patients misunderstand directions nearly 60% of the time. Ineffective communication can lead to poor treatment adherence and outcomes. So with that in mind, how can patients bridge the knowledge gap between what their doctors are saying versus what they are hearing? Dr. Edgerton, can you weigh in first here?
Yeah, well, I'll go ahead and just say that, Tunde and I are not normal people anymore, because we speak medical ease every day, and and it just becomes a part of us. So I apologize in advance that it seems to make sense to me, and I know when I really think about it, that a lot of what I say probably doesn't make sense to other people. So it's important, I think, just to raise your hand and say, that doesn't make sense to me. Practically speaking, one way to do that is just repeat back what you hear. That's really helpful. So, I kind of give someone the overview of what their prescription is going to be. And if they kind of speak it back to me and it doesn't sound right, I'm like, okay, that didn't go through. So that can be one strategy, so that you don't necessarily have to try to guess what someone said, but just speak back what you hear.
Great. Tunde, do you have anything to add?
Yeah, definitely. So yeah, communication is key. So oftentimes I'm repeating, I might repeat the brand name of the medication, the generic of the medication. I might spell it out for the patient, just if it's a long word like buprenorphine and they're on the prescription and they're like, hey, I recognize there's a B in this. Little things like that to create as many touch points as possible, because I know that so much is happening in the visit, right? Like, this is the first time you're probably seeing me in a month or two. You might be in acute pain. You're focused on that. You might have been having a bad day that day. And then when you finally get to the appointment, it's like, oh, shoot, I forgot what to ask. There's so much going on. And then you get to your pharmacy and it's a whole nother thing. So I really just try to repeat the education as much as possible. And to Dr. Edgerton's point, at the very end, I usually do a callback method where, I might ask them, okay, can you repeat back to me, relatively what I said, or at the very end, I might ask them directly, what questions do you have for me, if any, just to really make sure that that communication is sealed off at the end.
Those are such good points from both of you, especially, if that patient, like you said, if they're in extreme pain at that time and they can't even focus on what you're saying, going back and forth, making sure they get it is really helpful. We actually had a question that came in from one of the webinar attendees. They said, should someone bring a family member or friend to help with this decoding process?
Absolutely. It is such a great idea to have a second. As I talk to patients, I say a second brain involved. And when I walk in a room, that's kind of my thing. If I see another person in there, I thank them for being there, because it really just takes the heat off of the patient when you have someone else there listening, who's not kind of in the hot seat trying to answer the questions and taking it in. And go get a cup of coffee or some lunch afterwards, and they can talk about what actually happened and kind of cross level a little bit. So that's a great idea. I would always encourage someone to bring someone with them.
Wonderful. So what are some resources patients can ask for to help them better understand their treatment plan?
So I can take a stab at that.
Sure.
Every specialty will have usually an advocacy organization, as well as the specialty organization that offers high quality education. So for example, when it comes to arthritis care, if you go to the Arthritis Foundation website, they do a wonderful job of explaining every condition that has anything to do with arthritis. And we in our practice will print those materials out for patients when a patient gets a new diagnosis, and periodically just during the course of their follow-ups to remind them of things. But you can go there yourself. So if you happen to be in your orthopedist office, there's the American Academy of Orthopedic Surgeons that has great information. In rheumatology, there's both Arthritis Foundation and the American College of Rheumatology, and I'm sure other specialties have them too. So that's a great place to start. Good trusted information, and then you don't have to kind of pour through all of what Google gives you necessarily.
I'm a big fan of that search bar on the Arthritis Foundation website. I use it
Definitely.
frequently.
It's great.
Tunde, anything to add there?
No, yeah, I would agree. Dr. Edgerton, going to those specific organizations. And, when you go into your appointment, you'll often see that same marketing material kind of lying out on the tables, and maybe even in the clinic space. So, feel free to, read through that, grab one, keep one. And again, kind of just rely on your care team for any additional information to fill in the gaps.
Very good. Well, some patients may not want to bring up certain controversial topics like trying new therapies or switching medications or even taking drug holidays, as some call it, for fear of being judged or immediately shut down by their healthcare provider. We actually had a write-in question that was written ahead of time. I want to see a naturopathic doctor, but I'm afraid of what my doctor may say. How can I give my doctor information or broach the topic of complementary therapies without being dismissed or even offending them?
No, it's a great point. I mean, and it's difficult because a lot of the natural-based therapies have kind of a different way of thinking and a different approval process, or you will, or a different way of getting into use than a lot of what's coming from the traditional kind of world of clinical trials that your care team may be familiar with. So I will say that don't worry about it. If your physician doesn't really know much of what you're talking about, how they respond is going to be kind of a personal thing. They may not like to sit in front of you and not know about something. So you might see some of that, like you would with a colleague at work, if you're talking about something and they get uncomfortable that they don't really understand it or know about it. But it's just human nature, and a well-rounded person should be able to deal with it. I'll put it that way. So it's better to, I think, as we were alluding to before, get that off your chest and get those questions out there, particularly if it's important to you. And a good provider, someone who's used to seeing patients and dealing with all sorts of situations with emotions involved, will get through it. And if you feel like that person is not caring for you the way that you should be cared for because of something you've said, then that's not a relationship you should stay in with that provider, I would say.
Okay. Well, there was a follow-up to it, to that question, how to start that open dialogue about any trickier subjects, not just the one mentioned here today.
Yeah, so I encourage my patients to really explore anything that might work for them. I don't try to. It's not to say that like I'm sponsored by any one company or medication or whatever. I'm really into what works best for you individually. So I actually have a interesting situation. So a patient came to me one day and they asked me about ashwagandha, and I had never heard about it. And I was like, oh, that sounds like an interesting method. And I Googled it and things like that. And I'm very proactive, and I was like, maybe I'll try it one day and see what effect it might have. And actually I have it somewhere in here. But yeah, little things like that. It's like, at the end of the day, you're human. Not everything's gonna work for everybody. So if you find that there's one, oh, here it is. Yeah. So if you find that there's one thing that works for you, and no matter how ridiculous it might sound or how quote unquote like uneducated or whatever the case may be. I mean, everyone's going to have an opinion, even, potentially your healthcare provider. To Dr. Edgerton's point, it's not to say that you have to stay with that one provider if you're uncomfortable, so I encourage you to really take control of your healthcare, do what you feel is best for you, because at the end of the day, all it is a medical opinion, right? We can only offer you what we know, and from the education and the evidence-based material that's backing it, but it's not to say that it's a one-size-fits-all kind of situation.
Okay. Here's another tricky subject that we'd love your both of your opinions on. How to tell your doctor that you're seeking a second opinion.
Yeah, that's a great question. I will tell you, in rheumatology in general, we welcome second opinions. It is the nature of our specialty that the diseases are rare, the presentations are variable, and there's a lot that we just don't know. So we should be humble people if you go into the specialty of rheumatology. And when someone is looking for a second opinion, I encourage it. As I say, it's great to have a second set of eyes on your case, and let's see what they have to say. It shouldn't be a threatening thing. I know there are different personalities that might take that differently, but again, just like Tunde was saying, at the end of the day, we work for you. I'm here to give you opinions on how I think your health could be improved, and if you want more than one opinion, then absolutely go and get it. And I would say the only kind of logistical glitch sometimes is, okay, who do you go with? And that's oftentimes just a decision you have to make. One of the things that happens quite a bit in rheumatology is someone may go to a center of excellence like the Mayo Clinic or the Cleveland Clinic, get a second opinion, then come back to their locale where they live with that information, and their local rheumatologist will then incorporate that into the plan, and that's very appropriate. It becomes more difficult if there's a big difference in opinions, and then someone wants that enacted by an individual who didn't come up with that opinion. So you can get stuck in some of those situations, but in general, I encourage second opinions.
Very good. So, and again, I'd love to hear from both of you on this one. How do you help a patient who wants to maybe switch medications or take a drug holiday, which I'm sure you've both heard from patients before? Tunde, do you want to go first on this one?
Yeah, definitely. So, first and foremost, it's education about the medication specifically in terms of whether or not it requires a tapering, whether or not it's safe to just outright discontinue. So I'm always curious as to how the patient is taking the medication first and foremost. So, I'm sure Dr. Edgerton's had a number of numerous cases, but you ask a patient how they're taking the medication, come to find out the whole time they actually haven't been taking it appropriately, or they're taking it in a way that hasn't or wasn't initially prescribed. So I'm always curious to ask them, like, hey, how are you taking the medication? What time of the day are you taking the medication before discontinuing? Because that, it might just be a user kind of situation, and you could have quickly remedied that entire situation. But if the patient just is not agreeing with the medication, whether it be for side effects or whatever the case may be, then again, that's a situation where I'm always open to explore other options and see what else is out there that's actually going to provide the patient with relief. Another saying that I usually tell my patients is, hey, I believe the best medication is the medication you're actually going to take. So again, my opinion is one component, but it's not the end all be all. So I really like to include my patient in their decision making. And if I know medically it's approved and then they agree with it and it checks off both of those things, then I'm definitely in favor of it.
Yeah. Dr. Edgerton, do you have anything to add there?
No, I think that's a great synopsis. It's just really important to know if there's a problem with the medication or someone wants to try something different, just to get that out and talk about alternatives. We're aware there's great data that's been coming out of the pharmacy world about the problems with adherence to medications. It looks like probably on average 40% of people don't take their medication the way it's prescribed. So that information is known, and it's not gonna surprise any provider that those issues are there. And a lot of that is due to people who are having a problem with the medication, don't take it, but then don't seek an alternative. So I'd rather they seek an alternative.
And then we do also hear about patients who cannot afford the medication, so they skip doses and take drug holidays for those reasons. And I think I don't remember who mentioned it, but somebody earlier mentioned if it's a cost issue, that's something else that you need to bring up to your doctor.
Absolutely.
Yeah. So
certainly, yeah. And
go ahead.
I was just gonna add there are resources available as it relates to like prescription discount savings and things of that nature, whether it be GoodRx or other. And there's also other methods as well. There's things that you can do at the pharmacy to say, hey, you can communicate to your pharmacist that I want to do a partial fill, meaning they won't release the entire prescription to you if it's a financial reason. And then from there, you can just come back and get the rest of your prescription.
Right. So many doctors have biases that affect patient care, even if they aren't consciously aware of them. This is especially true for women, older patients, patients of color, or those who are overweight. There were many patients that wrote in ahead of this webinar saying they feel like their doctor doesn't take their pain seriously, and they want tips for conveying their pain without seeming like a complainer. So again, would love to hear from both of you on this one. Dr. Edgerton, would you like to go first here?
Yeah, it's a great point. It is so difficult when you're the one experiencing the pain, trying to convey that. And the words available in our language are limited, far too limited. I think what's helpful is sometimes thinking about how the pain impacts your function and being able to convey that. So I think you were mentioning before, Cristina, I have knee pain. Well, what did it stop you from doing, right? I have knee pain and I can't climb to my bedroom on the second floor. Well, I've been sleeping on my couch for the last week. That really is an impactful statement that makes someone say, that's more than, you're 60 years old and your knees hurt. Well, we kind of expect that, right? So maybe trying to link the pain with a decrement in function could be one strategy to help emphasize what you're trying to express.
Tunde?
Yeah, I would agree with that. Activities of daily living, if they're impacted to that degree, certainly makes an impression, or should make an impression on your provider, as to the quality of life that you currently have as a result of your pain. So, something else that I just do as well is just, simple 0 to 10, 10 being the worst pain you've ever felt, like trying to characterize the pain in that way. As well, if we are in a physical setting, doing things like actually laying hands on the patient to see if I can exacerbate the pain acutely, just to kind of measure it even further. So, again, I mean, it's unfortunate that that's the reality for a lot of patients, that they have to almost convince their provider that they're in
Mm.
pain. So I can only hope that the provider that you're speaking with is one who's empathetic to your needs, and one who can appropriately address them.
Absolutely. I mean, and I think setting, applying it to the practical everyday needs that you have. Maybe I can't do my hair in the morning. I can't dress myself. Those are pain. Pain is very different from I would like to be able to run a marathon. There's very different levels of pain. Not that that's not amazing running a marathon. I'm just saying from a doctor's perspective, I can see how you would look at that very differently, and want to address it as much as you can. So how can patients best find a doctor that suits their needs, depending on race, gender, or healthcare access? Tunde, would you like to start here?
Yeah, great question. So, oftentimes the best providers, in my experience, even me as a patient, have come from word of mouth, whether it be family, friends, organizations, just in passing, saying, "Hey, like, this was my experience with this particular provider. Feel free to reach out to them," and kind of going about it from there. So I would start with word of mouth. And then again, there's also, if you have insurance, calling your insurance to say, hey, because that's always going to be a barrier as well, finances. So calling your insurance to see who's actually in your network. So that's one less conversation or one less surprise, awaiting in the future.
Yeah. Dr.
Yeah,
Edgerton?
I absolutely agree with that. I think that you could ask any healthcare provider that you see that you're comfortable with for opinions on people in the community, regardless of their specialty, because we really do practice in a network and we hear feedback from patients about all of our colleagues. So
Mm.
if someone were to ask, me about, I'm looking for a provider with sensitivity in this or that regard, we can give them opinions, and you can ask a provider who really has nothing to do with that particular problem. Although ideally your primary care team would be the first place to start with that. And another resource can be the practice or hospital websites. A lot of them now have great bios on their providers, and sometimes short videos, so you can kind of see how they talk, um, and what some of their thoughts are. Although not everyone's great on in front of the camera, keep that in mind, but might still be a great provider for you. So there are those resources out there.
Kind of tied into that a little bit. Would you be able to share tips for on how healthcare providers can help patients maybe with insurance issues they might be experiencing, especially maybe VA or TRICARE?
Sure. It's I will tell you it's very difficult. The problems that patients have navigating what their plan covers and what the different nuances of the plan are just as difficult on the provider side. And I think the unfortunate thing is um, that system is designed to be complex by design, almost to be difficult to navigate, if you will, as a system of triage to keep people from accessing services, in my opinion. So it is very difficult to navigate. I'll tell you, in rheumatology, one of our challenges is getting access to some of the more expensive biologic medications for patients. So we've become very good at it, and we can help patients in that regard. So you lean on us when it comes to if you have a new prescription for a medication that you have to jump through prior authorization or step edit hoops. We and our staff can do a lot of work with you trying to get you that medication through the process of appeals or peer-to-peer discussions with insurance physicians and things like that. When you mention the bigger kind of bureaucratic systems like the military and the Veterans Affairs, there's varying levels of expertise, I think, that you'll find among different providers in their ability to understand those systems. So you might have to hunt around a little bit, and that's where I might reflect back on what Tunde said is kind of there's, ask those questions, because there's good word of mouth out there on people who might be better at navigating those systems than others. Some who have either worked in a VA hospital or trained in a VA hospital, or people who might have a military background with their medical training in the past would probably be resources for you.
Okay. Following up on or kind of getting back into the biases mentioned earlier, one of the webinar attendees said, but sometimes even using Dr. Edgerton's recommendations, some doctors are dismissive because they have an inherent bias against some patients because of their weight, socioeconomic status, and other preconceived notions. How can patients better advocate for themselves? Or when do you know that it's time to find a new doctor? Would either of you like to jump in on that one?
Yeah, so that can certainly be a challenge to navigate, and oftentimes you don't really have those conversations until you're kind of knee deep into the relationship with your provider, and then you realize, oh, this is a barrier. This is what's happening. So again, I try to be a provider that encourages my patients to speak on exactly what it is that their needs are. And if their needs aren't being met, whether it be with another provider or even me, I'm more than encouraging enough to say, hey, there's 8 other providers at my practice. I think this one would actually suit you better. They have a similar background, similar understanding, similar frame of reference, and they can really speak to your needs and handle your care better than I can. And to Dr. Edgerton's point as earlier about humility, I think that's just a human thing. You should be able to recognize your own shortcomings and being able to be humble enough to say, hey, I might be great for some patients, but, in other cases, you might need a different kind of provider. Not saying that, I'm biased or anything like that, but I really do try to make sure that patients are being paired with the most appropriate provider at the time that they need one.
Yeah. I know for me, just from the patient side of it, I think you kind of know right away when you meet a doctor how that relationship might go. And I try to be the overly prepared patient all the time, but if I don't see the doctor as kind of meeting me there, then I know this is probably not going to work out. So if I'm not feeling that mutual respect when I'm bringing everything to the table that I can bring to help, then I think you just kind of know as well. Excellent. Well, now I think we're going to take some time to get into some more questions from the attendees. Please keep in mind we received several questions before and during this event, so we'll try to get through as many as possible. But for the questions that we do not have time to get to, we strongly encourage you to visit the Arthritis Foundation helpline. You can find that at arthritis.org/helpline. We also received several questions about pain management, complementary therapies, supplements, healthy eating, all of those different topics. So as a reminder, we have webinars on all those topics that are easily accessible on arthritis.org/webinars. You can see previous webinars there, and you'll be able to sign up for webinars in the future on that same website, arthritis.org/webinars. All right, so with that said, let's dive into the first question. How often should I go in between doctor's appointments for regular arthritis checkups? And this could be for either of you, whoever would like to take that.
I can take a stab at that. I wish I could give you a short and basic answer to that, but unfortunately, it kind of depends. It will depend on how new your diagnosis is, For example, if I see a patient and I newly diagnose an inflammatory arthritis like rheumatoid arthritis, the initial follow-ups will be closer together as we try treatment and observe for how that's going to work, and monitor for any side effects or things like that. And then once the care is more stable, it starts to be dictated by, are you on a medication, for example, that requires laboratory testing at a particular interval, or are we expecting there to be any more chronic change? So using rheumatoid arthritis as an example, a typical journey might be you see the rheumatologist at day 0, you come back 2 weeks later to review a whole bunch of laboratory and radiographic testing and confirm a diagnosis and make a care plan. You might then come back a month or 2 after that to see how initial therapy is working. And then if things are going smoothly, it might be every 3 to 4 months after that, kind of in perpetuity. So that would be kind of one way it might work out.
Yeah. Do you have anything else there, Tunde?
No, I would agree with that. Newly established patients, you generally want to see them a little more frequently, just to provide that oversight, make sure everything's working smoothly. And then once you are established and everything is stable, those follow-up visits tend to be a little more spaced.
Yeah. And I think no matter what time frame it is, whether you're seeing your doctor every 2 weeks or you're seeing them every 3 months, I think that that logging and tracking and all of those things we mentioned, it's equally important, because if you're not seeing them for 3 months, you're going to forget. But if you're seeing them every 2 weeks, it's urgent that they know what's happening so they can best treat. Another question that came in: if you've had multiple replacement surgeries and you like your specialist, is it okay to go directly to the specialist, or is it better to go to the PCP or rheumatologist first?
So if I understand the question correctly, multiple joint replacements?
I believe that's what they're referring to here, yes.
Okay. So someone who's had multiple joint replacements and maybe now is looking for kind of follow-on care for their arthritis symptoms. I do think when you've seen someone and have had a surgery like that, and there may be sort of ongoing monitoring of how you're doing, functionally and pain-wise from those surgeries, continuing to see that team that perform those surgeries on you is very appropriate. Kind of expressing that and making sure that that's something you advocate for yourself is very reasonable. Now, that being said, too, if you were seeing a rheumatologist for, let's say, rheumatoid arthritis, you went and had a knee replacement done, you could absolutely get ongoing care from the rheumatologist to include management of continued pain or functional limitations related to the surgery moving forward. You don't necessarily have to keep going back and seeing the orthopedic surgeon for routine follow-up for a joint replacement. In fact, many orthopedic surgeons will kind of discharge the patient after that surgery is complete and their therapy is complete, unless the patient asks to come back. So rheumatologists are comfortable seeing patients who have had surgeries to the joint and still might be having some functional problems with the joint. And if something really goes wrong with that joint, they'll get you back in with that orthopedic surgeon.
Great. Tunde, a question here for you that came in. My pain is severe and I want to be put on pain meds, but my doctor is reluctant. What can I do to get them on board?
Yeah, so great question. Especially just as it relates to the ongoing opioid epidemic in the country. A lot of providers have been reluctant to prescribe opioids, just as in response to all of the regulations that have kind of happened over the last maybe 2 to 3 decades. So, and that's always a nuanced conversation, especially for the patients that I see, just because you have a legitimate medical condition that requires treatment. But oftentimes, as a result of everything that's happened, even chronic pain patients can unfortunately be grouped into those of those who might suffer from opioid use disorder or dependence. So, I would that's usually a situation where a patient might have to call different clinics and see, what exactly is your perspective as it relates to pain, right? Because everybody's philosophy might differ. Some people might say, hey, ibuprofen, Tylenol is needed. Some people go, immediately to opioids. And then there's other type of pain management options like naltrexone or just other, not as traditional methods. So, if your provider is someone who is reluctant, it's unlikely that a conversation with them is honestly going to change anything, just because they realistically speaking are trying to protect their license, and that's fair and valid. So it may be a situation where you have to utilize a different provider, or see what other methods are out there. Again, there's so many different methods outside of opioids that are effective and can potentially treat your pain. So I wouldn't just be fixated on that one thing, because honestly, that can be masking your pain as well over time. And there's also rebound pain that might occur from chronic use of those things too. So I would just be open to exploring other options and seeing what else is out there to effectively treat your pain.
And keep up the communication. If the option they're giving you isn't working, tell them, right? Another question here, how accurate is ultrasound at diagnosing inflammation in arthritis, and how does it compare to MRI?
Well, the ultrasound is a great tool for inflammatory arthritis. One of the real benefits is it can be there right at the bedside, if you will, when you're seeing either an orthopedist or a rheumatologist, and they can examine the joint very quickly. We kind of refer to it as the stethoscope for the joints because it gives us a real look at what's going on. It doesn't lend itself to examination of every joint. There's some deep areas that need a different type of imaging. So that's where a modality like MRI can be really helpful. So there are some differences in the capabilities of the different technologies, but in general, the ultrasound examination is really helpful and very accurate. And it's been around for quite some time now, and certainly in rheumatology and in another number of other specialties as well for sort of bedside imaging. So it's, I encourage patients to ask about it and seek it out, because it really does open up a lot more potential for diagnostic accuracy when you see your physician.
Okay. Another question here, how do you go about establishing a new doctor, either because the one you have is a bad fit or you are moving?
Yeah, so that's often the case for some patients who have to relocate, and you're having to kind of reestablish your bearings and see what especially it can definitely be challenging if you've had a good provider and because you had to relocate, now you're trying to reestablish that connection with a separate healthcare provider. So first and foremost, I would make sure that your records are able to be transferred, or at least you can take them with you, hopefully, with wherever you're going, so that you're able to then facilitate that relationship with the new provider, and they're not having to, reinvent the wheel and ask you all the questions that have already been answered previously by your original provider. So that's one thing that you can do. And then the second thing, just in terms of navigating maybe some of the financial barriers or other things of that nature, again, would be to, contact your insurance and see like, hey, I'm interested in maybe this local provider. I just want to make sure that they're within network, and if they are, then, great. You can kind of go on their website, see what kind of providers they have. And if they are in the specialty that you're looking for, then you can quickly get established that way. And then when it does come time for the appointment, you just provide that the documents and the information that you have. And, hopefully from there, those conversations will be a little easier.
Okay. We talked a little bit about this earlier, but what can someone do before an appointment to make their first appointment with a new doctor go smoothly? And for context here, this person, there's a 3-month wait for this person to see their doctor. So they really want to make sure they get everything covered. So any suggestions to make sure that goes smoothly?
Yeah, and first thing I would say is you can be proactive in continuing to check with that practice. You can usually get in earlier if you're kind of giving them a call every day and just saying, do you have any cancellations, either today or tomorrow? Because I know a lot of people, if they can't do a same day, change your schedule around and try to get in for an appointment. But cancellations happen, and actually a lot of practices have difficulty filling a new patient cancellation in a quick manner because they have to go to a waiting list and try to call people, and it just takes time and people don't pick up their phone. So be persistent in trying to get yourself in. Usually you can get in faster than that based on cancellations. But that being said, if it truly is 3 months and you just can't get in any faster than that, those strategies we mentioned before, which is kind of in an organized fashion, try to think about when your symptoms started, how they impact your function, starting to log those things, gather any information from the other specialists that you've seen, particularly X-ray results and laboratory results, and just have those copies of those ready to hand to the care team that you see. That's going to go a long way.
Very good. Another question that came in here: I have many symptoms of RA, but have only been diagnosed with OA. How can I get my doctor to refer me to a rheumatologist?
Yeah, I mean, you should just be able to ask for that referral, and if it's not forthcoming, really ask for a justification for why that is. If it's something you're concerned about and you're sophisticated enough to know about both conditions and the differences in those symptoms, I think it's a very reasonable ask to have an expert set of eyes go over your case. So advocate for yourself, and if that's not happening, maybe it might be a little bit of a red flag for you to seek a second opinion there from whoever it is who's holding sort of the keys to that referral for you.
Yeah, excellent. Question here that I think would be great for you, Tunde, to answer. What should I do to get my doctor on board if I want to get a certain lab test, imaging, or be put on a certain medication?
Yeah, so really what I would do is any little bit of education or any little bit of research on what it is that you're trying to pursue. And going back to Dr. Edgerton's point is, kind of asking them like, hey, this is what I want to do. If they are kind of pushing back, kind of just ask them why is it that you're, what you're trying to seek out isn't getting approved, or why is it not what they would recommend? Especially if it's something that, you feel would be critical to your health, if it's a simple blood lab, they should be able to get the requisition form and get that printed off. That's not a tall ask. So anything of that nature, even if it's a medication, the provider should be willing to have that conversation with you from top to bottom, letting you know how the medication might work, how it might impact, your health individually, and kind of just going from there. So I would just have that on hand. So that if you have, because I do it a number of times with my patients is, if I'm not their primary, I'll say, hey, like, I'm familiar with these medications. Here's a brief little list. So if that patient, I can imagine that patient going back to the primary care provider and like having that conversation. So I usually educate the patient as well as to like why the medication might work. So I would hope that those patients, let's say, if they don't have a provider that they're getting the medication from, maybe they saw it on a commercial, that they're doing a little bit of due diligence to see if it's actually something that's applicable, and then having that open conversation with their provider, just saying, hey, just want to explore it. Do you think this is within reason?
Very good. Another question we have here: I have OA in my thumb. The ortho told me that surgery was the only option. I don't want surgery yet. My pain is manageable. Is there a point where waiting is detrimental? And will it be too late to have surgery, or should I just listen to them and go for it now instead?
It's a difficult situation to be in when you have that osteoarthritis in those really high use areas like the thumb, low back, hip, and knee, which unfortunately, to some degree, we all get it as human beings as we age. So each case is sort of different, and I don't want to suggest that this would be medical advice that someone should specifically follow, not knowing the case. But I would say in general, osteoarthritis of the thumb, there's nothing you can do to make it worse, such that a surgery later will fail, whereas a surgery earlier won't. Now, there can be variations if there's tendons and ligaments involved where that may not be accurate. But in general, when it comes to osteoarthritis of the thumb, if the pain is manageable and the function is good, then surgery is usually not a considered option. Surgery is usually used as sort of the last measure to alleviate pain or to maintain function if the joint becomes completely lacking in function. So I would say, again, very general guidance on osteoarthritis of the thumb is if you're able to manage pain and you are having function that you find to be satisfactory, then you can just continue in that fashion.
Very good. Well, Tunde and Dr. Edgerton, thank you so much again for lending your time and expertise on this webinar. I've certainly gained some new insights, and I'm excited to apply these to create better relationships with my care team.
Well, it's been a pleasure, Cristina. This has been wonderful talking with you and Tunde and fielding these questions from the audience.
That's very good. And I didn't mention it earlier, but also Dr. Edgerton, thank you for your service.
Oh, thank you. It was an honor.
Absolutely. Well, before we sign off for the night, just a reminder, we have several resources and events to help you manage your arthritis. The Foundation's Live Yes Connect groups are a great way to get support and learn more about positive coping strategies to manage arthritis and your mood. Groups meet in person or online. You can visit connectgroups.arthritis.org for more information on how to join a community that understands you. As I mentioned before, the Foundation offers free webinars every month hosted by nationally recognized leaders in arthritis care. We'll kick off a new year of programming in January, starting with a webinar about reframing your mindset around arthritis to build better habits. What great timing for that. Check back on arthritis.org/webinars for a date and to learn more about this webinar and others upcoming, and of course, past webinars that you can watch the replay of. Also, it's Jingle Bell Run season. Join a team to help raise funds for a cure. You can go to arthritis.org/JBR to register and find an event in your area. And a reminder, in a few days, you will receive a survey asking about your experience. Please take time to fill out the survey completely and honestly so the Foundation can best serve you in the future. And last but certainly not least, a big thank you to our sponsors, AbbVie, Bristol Myers Squibb, Janssen, and Amgen for providing support to make tonight's webinar possible. And again, another thank you to our subject matter experts, and thank you to all of you, our attendees, for joining us on this webinar. We hope you all have a wonderful holiday season and a happy new year. Thank you.